Hello. So you were in the retrospective data for HER2, there was additional immunotherapy. But now we have a TKI with songertinib. That is second line. What are our concerns about toxicity? How do we have any data of going from chemo IO to a TKI like songertinib?
Well, I think that's for HER2.
Yeah,
so
for
I
HER2.
think that looking at the toxicity data, monotherapy with tyrosine kinase inhibitors seems to be the safest way to move forward. Because Jordi, Noemi, all of us, we have been mentioning a lot of combo approaches, EFR, and for me, toxicity management is probably one of the most important aspects we sometimes are forgetting. We have this efficacy data, and we are losing the point. So I think that monotherapy, if we got the phase 3 trial positive with tyrosine kinase inhibitors, that's my personal feeling in terms of tolerance, probably would be the best way to move forward. We are still keeping immunotherapy and chemo and ADCs for further lines. That's just a suggestion what I think the future will be like.
I was worried about like the immunotherapy before and then the TKI later.
Yeah, the sequencing approach
like
and the risk.
Yeah,
I don't think the data we have so far so that there is more toxicity after chemo immuno with adding a tyrosine kinase inhibitor in the second line approach. Yeah.
Thank you.
Yeah.
And Charo, following with there too.
Yeah.
What about the brain activity?
Yeah.
Do you think the TKI have activity in the prevention of the brain metastasis?
That's a great question. And again, I think we don't have enough mature data to say that. But again, it's going to be an element for decision, not only activity at the brain level in patients harboring brain mets, but the capacity to prevent.
So do you think in the future it would be the first line treatment?
Well,
better than the
we have to wait for the phase 3 trial, but it could be.
Probably.
Yeah, it could be one of the...
I also think it's less toxic than the ADC, no? So I think it's going to move
I just
quickly.
want to add something because I think the brain activity of these TKIs applies a bit for everyone, no? I would say the problem is that these are, the data we are presenting are based on the small clinical trials, phase 1, 2. We don't have large patients with brain metastases and with endpoints specifically looking at the brain. My guts tell me that these agents can be active in the brain. This is because with PAC mutations you have seen they are also very resistant and there's activity. So I think probably in the majority, or at least in the newest ones, we are going to see activity in the brain as more or less lower, but as we are seeing overall. Although I think that's my feeling, although I think that we don't have enough that data right now for the different HER2 insertions in exon 20.
Maybe one difference is regarding the size of the molecules. So small TKI, small molecules penetrates better in the brain and may have a protective effect on those patients that already they don't have developed brain metastasis yet. So we know that they are active in patients with brain metastasis. But maybe there is a difference with patients treated with ADCs, that we also know that it's active when the blood-brain is disrupted by brain metastasis, and these molecules are active. But we don't really know how these molecules are going to prevent brain metastasis in an intact brain-blood barrier. So maybe there may be a difference, especially in the first-line setting, by preventing brain metastasis with TKIs compared to ADCs, but this is just an hypothesis. I don't know, what do you think about this?
We have another question.
Just following with the hypothesis from Antonio, I agree with you. I mean, on this, we have having problem with these exon 20 insertions as well as this HER2 modest activity between 40 to 50% intracranial response. But then I think that the key will be perhaps the disease control rate in the brain. And so far in HER2, correct me, Charo, if I'm wrong, but perhaps a better quality of data for songertinib, because as I am aware, I haven't seen the sevabertinib data yet. And then the other issue is that data collection. A lot of patients perhaps receive radiation therapy, and then everything is confused. I mean, exactly what is the activity of these new TKIs in this space?
Yeah, I think you have raised a very important point. You know, we are missing patients with a small number of brain mets, sometimes treated with a whole brain radiotherapy with SRS. So we need to define more clearly the activity at the brain level. And I am not sure if the vast majority of the trials, I think with the new ones, for example, the compound from Nuvalent, they are just focusing on the brain activity. I think it's important to do this kind of trials, very focused on the activity at the brain level. That will be the difference when we have the final results. Yeah.
One question for Pasi. You mentioned patritumab, which is basically one of those ADC, a lot of promising, and also some activity on those bispecific targeting HER3 also. Any chance if you can comment on how we are dealing with the new ADC in terms of biomarkers, a lot of data with this new technology of quantification continuum scoring system, and perhaps that would be the way perhaps to rescue potential ADCs that perhaps lack of biomarkers, if you can comment on this, because we need a QNS in order to develop the NMR, the normalized membrane ratio. Can we do something like that with patritumab or ADCs?
That specific strategy is being tested prospectively for TROP2. I'm not aware that it's been applied for HER3 expression yet, but I think for the HER3 ADCs, not just the patritumab, but the bispecific EGFR HER3 ADC, and there's another HER3 ADC from a Chinese company. That is a needed space and needed, but there's been little progress to date, unfortunately. Tony can comment.
I can speak on that about the HER3 one. Due to the fact that it's two companies dealing with this drug right now, there's some discordance, I think, in a sense, is that I think their biomarker program is a little bit delayed for the time being. So I'm not looking at any near future of data coming up.
But I want to ask for this patritumab deruxtecan as ADC anti-HER2, the combination with osimertinib. I was asking about the potential combination with, because there are preclinical data that when we add the osimertinib, there is a higher introduction of the molecule, so perhaps the future could be the combination like that of patritumab deruxtecan with osimertinib to really not lose this potential target. I think it's really important in EGFR mutant.
Yeah, and there has been a completed phase 1/2 trial. It just hasn't been presented yet. So it's coming at some point soon.
Dr. Yang.
There's a question here for
Question
yeah.
to Pasi?
In the whole strategy of the GFR in the second line, when you use in the first line Flaura, you can rescue the patient with the Mariposa 2. But if, in your opinion, if you start with amivantamab plus lazertinib, which is the best option for the second line, the ADC, the EVO, or the platinum doublet with like Flaura plus osimertinib? In the normal clinic.
If you use, probably some form of chemotherapy or ADC in the second line.
And you move the EVO EDC at the third line.
Remove what?
You move the third line ADC or
Yeah, I think if someone who's treated with, so ADC would be third line. If someone's treated with FLAURA2 regimen, then probably ADC becomes the next second line standard of care.
Okay.
At least it's more appealing than docetaxel.
Yeah. Everything is more appealing than docetaxel.
Because the GFR TKI is not needed in the second line every time.
I mean, I think that's a question that still needs to be
Yeah.
answered. I mean, from the compelled data that you're showing, it does suggest a
Right,
continued.
there's a continued
effect.
benefit now. Yeah, but that hasn't been really explored with
That-
docetaxel or
Yeah.
ADCs yet.
But there is the randomized phase 3 trial for Tropion-15 that is asking that question,
Yes.
randomizing to Dato-DXd plus osimertinib
And
and
it's
chemotherapy.
better
So
maintaining
we'll be
osimertinib.
able to tell, hopefully, the contribution of osimertinib there.
Do you think that is interesting, the approach that you mentioned previously, that start with osimertinib and after one cycle or two cycles move to the combination?
Well, I mean, I think that's a more pragmatic kind of solution, and I do, when I encounter patients that have all these different options, it's very difficult. They get almost to a paralysis on, and even there are some patients that are very clear of what is important and what they want. That's fine, but I think that a lot of them are digesting a lot of information, and I think if there's one cycle, 3-4 weeks later after they have the initial run of osimertinib, I think that's not too late, hopefully, for us to implement our combination.
Okay.
I think
There was some question over there.
Okay. Thank you very much for a great roundtable and a wonderful discussion. Sorry for moving the topic to KRAS. I share many of the concerns that Jordi presented in his presentation, and especially the clinical relevance and the use of the presence of co-mutations for KRAS mutant patients. This information is becoming more and more available in our clinical practice. We have this information in hand today, and in 2 years from now, where many of those trials that Jordi presented will become approved, this chemo plus IO plus KRAS combination, the so-called triplet, or the chemo or the IO plus KRAS combination, when they become available, we will still don't know which are the patients that we would like to intensify our treatment with a triplet or maybe de-escalate with a doublet. For example, none of those phase 3 trials in the first-line setting, to my knowledge, is stratifying the patient according to the presence of co-mutations. So when I have a patient in 2 years from now with a KRAS G12C mutation and, let's say, an intermediate PD-L1 expression, and the patient has also an STK11 mutation, I will not know whether I would need to intensify to this patient or not, because none of the plethora of those trials that we have in the first-line setting is stratifying patients according to those important prognostic factors. This is my concern.
Yeah.
Triton trial doing that?
No, I fully agree. The issue is that I don't know if there is any preliminary press release, but if the Triton trial is positive, then what we'll do in our practice, if you have a KRAS G12C STK11, or also because the trial is KRAS, the Triton trial is KRAS or STK11 or KEAP1. So perhaps the future for KRAS per se will be chemotherapy plus a dual immunotherapy. So perhaps we'll make to extrapolate to make this Triton plus the KRAS G12C inhibitors, despite there is no data. Otherwise, we can lose the activity of this dual inhibition if this trial is positive. This was one of my concerns. But for this, I said perhaps we are moving too fast to be in the first line, but we need to stratify, because adding, it's not the solution.
So my concern regarding that, beyond the prognostic factors, is the feasibility of the triple combination of chemo-IO plus the KRAS inhibitors, especially when you are going to know the allele specific, but the pan-KRAS or the pan-RAS, so the toxicity will be higher. It's not really well tolerated. That means that there will be low compliance for some patients, for certain patients that have to interrupt the treatment because of side effects, either diarrhea, pneumonitis, hepatitis, whatever. And the thing is that the most important drug that these patients are receiving in the first line is the immunotherapy. You already presented the FDA retrospective data that immunotherapy really benefit these patients either alone or in combination with chemo. And we had to halt the treatment because of side effects with the only treatment that will make an impact in overall survival, whereas any of the KRAS inhibitor haven't proven overall survival benefit yet. We know that it's immature, but to keep the KRAS inhibitor in the first line, we have to stop immunotherapy in certain patients, sometimes for a while, like 2-3 months to wash out all the toxicity of the combination. So I'm really concerned about the tolerability of these combinations in the first line setting, and we are pushing a lot of many trials in the first line, and some patients discontinue early the treatment with immunotherapy because of the side effects. Sometimes you don't really know where the side effect is coming from. It's coming from the KRAS inhibitor, it's coming from the immunotherapy, and the protocols sometimes are not very clear about what the treatment you have to discontinue in that situation. I don't know about your experience with these triple combinations, but some cases are really challenging.
Maybe we are forgetting in this regard, because it's very interesting the question, just to how we can harmonize all these approaches, is the fact that German group, and also from the north of Sweden, a strong publication, robust information, just only IO in KRAS G12C combined with P53 mutations plus PD-L1 more than 50%, only monotherapy with IO. The PFS was more than almost 3 years, the median overall survival 60 months. Therefore, these data are not negligible because are very important. Just that there are, I personally consider that KRAS inhibitors, all classes of KRAS inhibitors, are essential nowadays as upfront treatment. The combinations with chemotherapy, as following the stream that has been provided in FLAURA, so on, is also very important, and so on. But the combo with IO still have some limitations for toxicity, as you know, liver hepatotoxicity, but also is very compelling these observations that KRAS G12C, when you have also commutations of P53, that is very nefarious in general, but in patients with also PD-L1 more than 50%, two groups, the German network group, and the published in JCO, also a group from UMEA in Sweden, both demonstrate that PFS is amazing with only Pembro or Akin, IO. PFS almost 3 years, you can imagine, and median overall survival of 5 years. This is also important, and NGS obviously matters in tissue, but especially in blood.
Going back, I'm going to return back to the EFR now again. Yeah, question for Daniel. So we clearly, I think that all of us, we will agree that if the patient has high-risk feature, we will use a combination rather than osimertinib alone in high-risk patients. Tango with the Mariposa and FLAURA2, now finally, after so many years using osimertinib alone from FLAURA, now we start to understand with data which are those patients. So in my view, personal view, I have 3 subgroups of patients in which I will use the subgroup analysis to make a decision in terms of therapy. I would like you to hear your opinion. Mine are A50A, that mutation, the presence of TP53, and the other is the presence of CNS metastasis. So someone in the prior session mentioned about changing the tumor biology. Are we changing the tumor biology using amilasertinib? That is first question. Certainly, as Pasi mentioned, we are not preventing, but we are significantly reducing that kind of mechanism of resistance. So that's one question. And then the second question, if you can finish your case, you present a case of an ever smoker with TP53 mutation. I don't think that I hear your opinion on how would you treat the patient. Wouldn't give you amilasertinib for that specific mutation based on the subgroup analysis of TP53?
Yeah, no, thanks for those questions. I would say that, one of the challenges with P53 is that there are many different types of P53 mutations. And I think we haven't gotten to that level of trying to isolate the functions. Because, for example, even in the FLAURA resistance mechanism paper, they made a special mention that missense mutations have a higher risk of suboptimal response. But again, that's not really the right necessary classification. That's just what the mutation is, but it's really which domain that it's affecting. And I don't think we've gotten sufficient data sets to get to that level. And I think it speaks to one of the earlier points made about how are we going to account for these groups when we have multiple trials that are going to read out in 2-3 years' time, and only retrospective data that will maybe guide us, and these are going to be a subgroup analysis, underpowered. It's going to be challenging. So I think P53 is, to me, a bit of an orange flag. I think the clear ones, I agree with you, CNS metastasis, and I would be, very counseling them for combination approaches. For us, it's going to be chemotherapy, given that it's a little bit more accessible. I think access and management of the toxicity profile is one of the key challenges with amivantamab at present. And it necessitates a selection marker, which is what I was getting at. Is there a MET selection marker that we can consider finding? And I think it's still elusive at this point in time in terms of making that decision in the frontline setting.
I want to make a comment. I guess for the ones that were doing lung cancer for 25 years or more, we came from terrible times. With carbopaclitaxel, we used to keep people alive for 1 year or 1 year and a half. I think when we're talking about EFR, to talk about high risk or low risk, I don't think it has a lot of sense to me, because how you can tell a patient, hey, you are at low risk, if 4 years later he's dead? Nobody wants to live 4 years. That's why we need to raise the bar. That's why I don't like to say low risk. How are we going to be low risk? Oh, you are good prognosis because you are exon 19. Then the patient will be dead. No, we need to cure people. So that's why we need to raise the bar. So that's why the best treatment is the treatment that cures. Because we are not there, everybody for me is high risk. Okay, if you want to be academic, P53, all of these things, if you add all the risk factors, pretty much 80% of the patients are high risk. So that's why I think for me, the combos have to be the standard of care. And you have to find a very special reason why you want to leave osimertinib alone. I'm from Florida. In Florida, I have 91-year-olds, 92-year-olds. I have 5 that are above 91. Maybe these are the only ones, but everybody else has to get a combination. And even with the combination, the survival of these patients is barely 4 or 5 years. So even with that, that's why we need to raise the bar in our expectations. And the way that we educate ourselves in our community. So you cannot tell the patient, oh, you are lucky because I found the EFR. The patient nobody is going to get cured with that EFR. That's why I think we need to change a little bit the standards that we're looking for. No?
I do agree with you that with 2 frontline combinations that improve both PFS and OS, a combination approach should be the standard of care, and with the default approach of the single agent osimertinib. But you're right. The OS, median OS could be, we're not curing anyone even with the combination. So I think there's opportunity to build on those.
Going back to the same topic on the median OS, so in Sunday is already February, so that will be 11 months since the press release from the Mariposa people. Yeah, when they when they said that the median overall survival is going to be 4 years or more, that was 11 months next month. So we haven't get that number. So everyone is intriguing, because I'm telling you, if I see a big difference there, I will go for the better is the best. Okay, so that's one thing. And then the other thing is the Mariposa start with our left foot, because when we remember the presentation at ESMO in 2023. That infamous New England Journal of Medicine with that kind of toxicity, because we have to report that, is infamous. Absolutely. This is all time, so we need to move on. And that's why we have all these Skipper IR clinical trial, the Cocoon trial, the VTE prophylaxis and everything. I mean, if we can improve, I agree with Luis, we need to raise the bar. And Charo, you don't know how many times I call you. I call your name in USA. Every time. I will tell you why. Because you and the co-authors, and I applaud your job, plus all your colleagues, when you teach us how to manipulate this bispecific monoclonal antibody. If we need to hold it, we hold it. If we need to skip 1, 2, 3 cycles, who cares? Yeah. Just do it. The idea here is try to keep the patient as longer in what we believe perhaps could be the best therapy. So I really applaud you and all your colleagues because you teach us a lot. Just simple like that. I just want to mention that because we need to move on. We cannot be on the New England Journal of Medicine, oh my goodness, Rush, who the heck is going to give anyone 26% grade 3, 4, 5 toxicity in the skin? No one. But we have doing much better. On the cocoon, the grade 3 was only 4%. But we need to apply what we have learned, okay, and start to forget about all these kind of toxicity. It's manageable. We know what to do. The other thing is the subcute has changed a lot. And this is without the Copernicus. I hope that the Copernicus people doing that research became positive because that AMI will go from subcute every 2 weeks to once a month. It's very nice quality of life when you tell a patient, keep taking the lacertine, I see you a month for your next injection. And also the other thing that we haven't talked is the immune modulation of amivantamab that already has been proven in patients with metastatic colorectal cancer, where we know that this biospecific is going to increase the NK and many other markers in the immune system. I don't know if anyone in the panel has something to say about this.
Daniel, you want to add?
Thank you, Martin. Thank you. We are ready. Go.
But I have to say, I have patients on amivantamab, and we are applying all this supportive care, and I have to say, it's still a toxic combination. So I have a 38-year-old woman with skin toxicity. We did everything, and she has a complete scalp, and I think we need very good data to have this in our routine practice, because we say, yes, we have made progress with tolerability, but I think just from a practical management point of view, it's a very toxic regimen. Nevertheless, what we are doing.
Okay. And I want to reply to the...
But very quickly.
30 seconds.
30 seconds.
The worst one that we can see is the scalp. So when you see what has been published in Cocoon, don't pay attention to this or use the clindamycin gel after 13 weeks. As soon as you see some follicularis in the scalp, start to use the clindamycin shampoo. Don't wait.
But it still is a challenge. Luis, the last one. Because
Okay.
we have lunch.
Because it's the last one,
Yeah.
I just like to be a bit provocative. Let's say, I tend to use prognostic factor the other way around. High-risk patients are benefiting less than good-risk patients. Good-risk patients are getting more benefit. So why should we use chemotherapy or amivantamab in combination for high-risk patients if they benefit less than good-risk patients?
So
That's for you, I guess.
So I mean, I think actually for all the prognostic subgroups, that trend that we see in the delta is, you always see the benefit of the combination. I'm actually more specifically looking at the ones where that delta is a little bit bigger, which again, hopefully convinced me that there is a bigger effect size and it's worthwhile if we encounter toxicities. So, I mean, I think this concept of good and poor risk, it's, yeah, you know, what?
Okay. Actually, being honest, I think it's been a bad help from pharma.
Yeah.
This is being a bad help for pharma. They like to secure some patients were treated with combos, and they give us this message of risk factor. Risk factors are not predictive factors, and I don't think we should use it the other way around.
I guess I have to join the debate since this is called a debate. Okay. So I agree about the prognostic bit. I also agree that there are some commercial from the pharmaceutical company. But I think, and also I also agree the fact that some of the toxicity are manageable. But the fact of this, we ask the question, the patient, what they want. I mean, I think that's actually the key. It's not how much we can decide for the patient, or you got so much medium number of months to be longer, or what kind of toxicity you're going to get. It's our job just to explain to the patient what there is and for them to choose. For 91 years old, I'm sure you can give them chemo, but if I have 91, I would not get any chemotherapy from you. So I think it's a patient's choice that is we have to emphasize on rather than just using pure scientific fact to make the decision. Yeah.
Okay, thank you very much. We have lost the time. Thank you.